All right, I'll start with this patient. This is a really unfortunate situation, as I'll show you. I don't have a chest radiograph, but it would look like this. I don't know whether at the time of initial presentation the chest looked like this, but at this time, going through the chest, we'll see a lot of pathology. There is a lot of fluid and atelectatic lung, and the primary lesion is down here. So this mass, one can see, is arising in relationship to this left sixth rib. So you can see that portion of the rib that's expanded by tumor, and this portion of the rib where there's some residual cortex is expanded by tumor. It's obviously very large. It extends into the chest wall. So given the rib location of it, it's certainly consistent with a primary tumor arising from the rib. And I just want to look further down to see whether on this image, perhaps on a follow-up, which I'm not showing you, in relation to pleural surfaces down here, which is not there, there were small areas of high attenuation. So this turns out to be a so-called telangiectatic osteosarcoma. And certainly one form of osteosarcoma that can produce a large mass and arise within the rib. And those sarcomas, osteosarcomas, need not have a lot of osseous matrix associated with them, even though this tumor is very big. But that's what this is. And the follow-up, which I thought I had findings in the basal hemithorax with, I thought, a little bit of ossified matrix, very suggestive of growing pleural implants of tumor, but I thought I had that, but I don't. This is a telangiectatic osteosarcoma, undoubtedly arising in that rib. A pretty nasty tumor, of course.
Hey, Howard, for the trainees watching, that case also has a nice example of a detector artifact from the CT. You can see that little...
yes, right there. Yeah, that ring artifact. I can't remember the genesis of it exactly.
Yeah,
it's somehow related to detectors.
Right, and it's usually because one of the detectors has gone bad, and so and that's why it moves around depending on where the image interpolation was done. So, but that's a good one for just also to recognize in practice, but also a good one for exams and other quizzes.
Yep, good. All right, I'm going to show you two unusual presentations of primary adenocarcinoma of lung. The first one is a 32-year-old person. At the time she had symptoms, and this goes back to October 31, she has a radiograph in which we have opacity in the left lower lung. Of course, ordinarily one would think this should be community-acquired pneumonia. And I'm sure that was probably the initial diagnosis made for that. But it didn't get better. The patient's symptoms, and I can't quite remember what they were, did not resolve over time. So the CT that I have here was not at the time of the initial presentation, because I see the dates are off, but this is a representative image of it, is this. So when we scroll down and we go to the lower lobe, here is a focal opacity, and it's got an area of ground glass attenuating. What's really around it, what's really interesting about it here is that you can see there is a cystic component of it right there. And it's interesting that there's a vessel that goes around that cystic component here. So this cystic component is, in a sense, occupying space. And then notice that there are other separate lesions, quite a few of them, in the lower lobe in different places. And each one of them has cavitation, or perhaps one should say pseudocavitation within, and small halos of ground glass opacity. So on biopsy, this turns out to be an adenocarcinoma of lung. I've certainly seen this before. But I'm not sure that I remember seeing one with so many, I don't think satellites is the right word, but multifocal tumors in the same lung. So I thought that was quite interesting.
So Howard, I have a case. I think I have it loaded up. Yeah, I have one we just saw that has the more exuberant in their airway spread of tumor and the little like Cheerios with the little cystic nodules. But I'll show one a little bit later that shows even more.
Yeah, and I'm trying to remember in terms of airway spread. I think this one was described as mucinous. So that may be another reason how it spreads. It does say mucinous adenocarcinoma on that biopsy report, as you see there. So perhaps the mucin carries the cells and then they grow in different places, right? Presumably. Okay. Here is another patient that has an unusual presentation. I didn't think when I first saw this was going to be a cancer because of some unusual imaging features. So the chest radiograph, I'll put up the lateral, looks like that. Obviously a large rounded opacity in the right lower lobe, right perihilar region. And let me bring up the CT alongside that. And first notice how low attenuation this is. The large mass either has a lot of necrosis within or there's some liquefaction, but I thought that was really quite unusual. I didn't expect to see a large lobulated opacity looking like that. And then I will show you that there is an endobronchial component here. And let me just scroll through that bronchus. And that clearly was biopsyable, so there's an endobronchial component there. But then there's this component as well. And biopsy, I think, of that as well as some lymph nodes. Let me have a look. Showed adenocarcinoma. So here you can see there is the obstructing mass in B6 into the bronchus intermedius. This is the bronch report. They did some biopsies. Adenocarcinoma of lung. And let me just bring up the coronal here and lung windows to show you the relationship of this thing with the interlobar fissures. It's really strange. It almost looks like part of this is growing within or in relation to the interlobar fissures, which is a strange pattern of growth of this thing. And then what I thought was interesting, and I wonder if this explains in part why it looks the way it is, and could it be super infected? So here is a lymph node that had cultures positive for strep and an Aspergillus niger group of organisms. So then I speculate to what extent some of this could actually be super infected perhaps and account for some of the imaging features. What do you folks think? Obviously we can't tell for sure, but I thought that was really quite interesting.
Yeah, it's awfully, really necrotic looking.
Yeah, and large.
But you do have that rim of soft tissue around it. I guess size alone is very concerning.
Yeah, really not quite sure what to make of that. I didn't expect to read that in the report when I got the follow-up, as you see there. So really quite unusual. And I think that they didn't operate in this patient because he's got metastasis to subcoronal lymph node, as you see there. So it's kind of an interesting presentation too, a little bit unusual. Let me show you a nice example of a sign that was published relatively recently. I've seen this before, but in the JTI, they published this double artery sign. So I'm going to show that to you. I'll just make this a little bit bigger. I've seen this before, I'm sure we all have. I never thought to give it this name necessarily, but it's the idea that on CT, you see adjacent to a vessel, another tube, exactly like it, but adjacent to it, just like that. and they call that the double Audrey sign. And of course, the idea being that something is present in that bronchus, opacifying it, maybe just mucus or something, but the double Audrey sign. So here is a really nice one that I saw the other day. In fact, there are several of them, but the nicest one is right here. So this one is in a bronchus right here in the upper lobe, and there is enough mucus accumulated in this bronchus right here that we can see the double Audrey sign. And I'll bring up the thin cuts just to go along with that. So let's see if I can get to the right spots. If I double click like that, it's going to be right there. So as I scroll through that now on the 1 millimeter sections, you can see that there's a bronchus here and it branches, so it goes anterior, but that branch that goes more posterior is the one that contains presumably mucus and fills quite a bit of it. And I always tell folks that the importance of knowing that is when you look at a CT, and we image a lot of patients follow up for cancer, that when you see nodules like this one, but it's adjacent to a vessel, look very carefully at the thin cuts like right there. And if you see that that little white spot is right in the lumen of a bronchus, like right there, you can pretty much conclude that it's not a metastasis. I see that quite commonly. I'm sure you folks do as well, but I find it very helpful to note that it's actually in the lumen of a bronchus. And sometimes these go away and sometimes they don't, but I've never seen one subsequently enlarge and represent an endobronchial metastasis or so on. But the nice thing about knowing about this is the differential for small nodules on MIPS is intraluminal material in an airway. Do you encounter that much? Do you typically look at MIPS when you look at follow-up lung cancer, not lung cancer, just oncology patients, and vexed with all the little nodules you see?
Yes. One thing I've noticed, though, that can be helpful, too, is when you have, you almost get like it's like a line of marching ants. You can see these endobronchial secretions sort of in a row.
Like here,
yeah, and
the
MIPS lay them out, so they may be on multiple slices on the regular images, but on the MIPS you can see them branching out from the hilum.
Especially in central bronchi, that they line up in these central bronchi like that. Yeah, those I see too. Those are relatively easy, but it's the ones in the periphery, the small guys, and especially when they're by themselves, that are kind of irritating. Like here, you're talking about they line up like in a bronchus like that. Sort of.
Yeah, you get a nice little, like a row of ants.
Yeah, exactly.
So one of our pulmonologists here, and if Mark Schiebler is there with Jeff, he knows very well, is quantifying mucus based on number of airways and segments that are plugged like this. So we're actually doing research, going through and counting these plugged airways, like you're saying, Howard, and looking for things paralleling the arteries is a very good, easy way to find them. So they're very common in asthmatics too. Yeah.
I always thought that, these would be on one image, and then the next time you follow up the patient, you would think that if it's mucus, they should be coughed up. But sometimes they're there again, they're exactly the same place 3 months later. And I've no idea why that.
Several years later, in some of our cases, we're doing these longitudinal studies, and they bronch the patients and find a lot of eosinophils in some of these. It's kind of interesting.
Yeah. I just describe them in my report as consistent with inspissated mucus, in part because I don't know what else to say about them, but always make sure that the person reading the report knows that they're benign intraluminal stuff like that. Yeah. Okay, Jeff, those are mine for this week. I can show a few more if we have time, but otherwise, let's start.
All right, thanks, Howard. Brent or Travis, do either you have cases?
I have some.
Okay, Brent. There you go.
Okay. Let's see. Okay, can you see? I guess you can see that screen there. So this is a 64-year-old woman who came in as an outpatient and had been having some shortness of breath. And you can already see as part of this coronary CTA that we did that the RCA over here is very, very dilated, huge. And can see there just particularly huge RCA. You can see before I scroll up to why that's going on, you can see also that the LAD is very, very large, and then branches of the circ are very, very large as well. And then going up to, you know, what's the cause of this? Looking for the origin of the RCA, not coming off of the sinus, right sinus of Valsalva, but coming off of the pulmonary artery here, right here. So this is ARC kappa, so anomalous right coronary artery from the pulmonary artery. And what's nice about this case is not only that you can see the anomaly here, but you can also see tons of collaterals from the left circulation that are coming up here and trying to perfuse, take over part of the RCA circulation because of the chronic steal phenomenon that this patient has had. So all of these are collaterals that are coming from the left coronary circulation and going over to provide portions of the RCA territory. So just a nice case of ARC kappa that has you know, been undiagnosed to this point in this 60 some odd year old woman. So I just thought that was a good case.
Yeah.
And let's see, let's go to the next case. Just a quick case. I wonder if people have seen this device. So this is a trauma patient who came in with this to Grady, and you can see that there's contusion on the right, and this device right here. Has anyone seen that device before?
Nope. Nope, never have.
No.
And of course, it's projecting over, you know, you can imagine, you know, if this were something shaped differently, it would enter a balloon pump, but this is actually a, let me pull up and see if I can switch to this. Okay, so this is the Rebola catheter, and this is a resuscitative endovascular balloon occlusion of the aorta catheter, and it's a balloon that's put up into the aorta and inflated, and it actually occludes all flow distal to that point, and it's used as a temporizing measure for certain cases of very, very severe trauma where it's difficult to even transport them from the trauma suite to the surgical suite or angiographic suite. So, you know, and the key word here is this is a very temporary, you know, maneuver because, of course, you're including all downstream flow. So this was put up, and then, of course, on the very follow-up examination, it was gone. So it's a Rebola catheter. So just a new device. I've had not seen this before this point. So.
Is it a new device, or is it just an old device that's very seldomly used? I've never seen it.
You know, Travis, it's either an old device that I just haven't seen, or you know, it's a new device. So I think it's fairly new or somewhat new, but I just never, you know, never seen it. So I assume because we see so much trauma that, you know, I assume it's relatively new. But so there was that. Here's another case I know. Maybe Jeff can tutor me in this case because it's just an interesting case of a congenital problem. And, you know, let's look at the scout.
We don't see, we still see your Rebola thing.
Got it.
Yeah, you have to switch it on the GoToMeeting.
Here we go.
There we go.
And you can see here on the scout here, the topogram, you can see that, you know, there is severe mediastinal rightward shift, and we don't see a right lung here. And let's take a look at the CT chest. This is I believe a 47-year-old man who came in with this, and you can see that scrolling through, you can see that the mediastinum is completely shifted into the right hemithorax, and there's no lung tissue whatsoever. There's no bronchial stump. Switch to the lung windows, and we have no right lung. And so, you know, a case of right lung agenesis. But what I find is the interesting thing here is that look at the bronchus, the left main stem bronchus. It's being compressed between the aorta and the pulmonary artery, and somewhat stretched because of the mediastinal shift here. And so if this patient had a pneumonectomy, you would be happy to call this post-pneumonectomy syndrome. But this is a congenital, agenesis of the right lung with a post-pneumonectomy appearance of the bronchus there. You can see that there is some air trapping there. And I don't know what this would look like if the patient were taking a breath out, but you can only expect that this might cause some problems over time, some obstruction of the existing lung here. So, Jeff, have you seen similar cases of bronchus being stretched in these cases, or?
I've seen it. It's unusual for patients to develop problems with it because they're only born with one lung. The present lung grows to accommodate the space a lot more, and the airway develops with it. So it's unusual to develop malacia or narrowing like you get with post-pneumonectomy syndrome. You wonder if the patient, there may be some air trapping there, but it may not be physiologic, because if you look at the caliber of the vessels in the darker lung, they're not particularly that small, suggesting there's not hypoxia there and vasoconstriction.
So they might have compensated for that.
That's my guess.
Over time. Okay. Yeah, I just thought that was an interesting appearance there. So
nice case.
And let's take a look. This was a case that just came in yesterday, and this is a cardiac case. And we didn't have much history on this case until we were kind of almost done reading it, but it has some dramatic findings. You can see here that they're on the Kanne, that there is very, very severe hypokinesis of the anterior wall and the apex here. And let's go on to some of the four chambers so you can see hypokinesis here. The T2 is interesting because you can see that there is a lot of increased T2 signal here, some hyperintense signal here that would suggest some myocardial, at least some degree of myocardial edema. You can see pleural effusions here. And here is the first pass perfusion. You can see this dramatic resting perfusion defect all along the anterior wall, the apex here, going from almost the base to the very apex. You can see that dramatically on the four chamber as well. Here again, dramatic perfusion problem here. And then look at the inversion recovery series of delayed enhancement shows that, so we're looking in general for areas of delayed enhancement that was just, scar in cases of myocardial infarct. But there's one case in which you don't see that, and you do have severe damage to the myocardium, and that is a case of microvascular obstruction. And you can see that there is very, very severe problem here with the whole region that was affected of the LED territory. That's an area of microvascular obstruction, and it's really one of the most dramatic, extents that I can remember seeing. It starts here at the apex and it goes all the way down. All this dark myocardium is essentially not receiving any blood flow at all. So it's a no reflow zone or a microvascular obstruction case that extends all the way up to basically the base here. So just a very, very extensive case of microvascular obstruction. The history is this patient had a very recent MI, and so a subacute MI over the last week, and had developed this microvascular obstruction. So it just shows you that this can occur within just short period of time of a myocardial infarct. So we had edema, suggesting the acuity of this, and then we have a large area of microvascular obstruction. So I just thought that was a really good case of it. Okay, I may do one last one. This is just a quick case of a patient who had a recent cath, and this was a non-contrast CT that was done. And you can already see that there is high attenuation material right here in the mediastinum. And you can see that it's closely opposed to coronary here, and you can see some high attenuation material in the pericardium there. And this is a case of a intraoperative or intracath dissection and perforation of the coronary, where injected contrast had had gotten out into the mediastinum, and so we have a perforation. and dissection here. So I just thought that was an interesting quick case there. So
the cath was performed a short while before this, relatively short while, right?
yes, yes. So just hours before this, the cath was performed. We still had some. They knew that they had caused a dissection, and they were concerned about some extravasation during the cath, and so got this immediately after. So I guess I'm just a little surprised that there there isn't more kind of stranding in the mediastinum and so forth, but there is. You can see that there's already been some transit to the pericardium there, so presumably of the same contrast. So
Brandon, it's probably because it's contained by the pericardium. That's probably why you don't see the stranding.
Oh, that's true. Yeah, it's helping contain it.
Yeah, it's pretty tough.
But I've seen some smaller cases of this, but this is like one of the most dramatic. Dr. Stillman showed this to me, so it's one of the more dramatic ones.
I may have missed it, but what did they do? What are they doing for it? Are they gonna? Do they have to surgically repair? Do they put a stent across, or?
No, I think a stent was put across. I'll check into that again though, because I'm not 100% certain, but I think that's that happened. So I don't think that they went back in with surgery. So, but I'll check that out and verify that.
It must have been angioedema.
Excellent.
Yeah.
Yeah, that's true.
Okay.
So anyway, those are my cases this week.
All righty. Travis, do you have cases this week?
Yeah.
All right. There you go.
All right, you guys see my screen?
Good.
Yeah.
Okay, this is an old one I showed a couple of years ago, but I'm going to show it again just because Howard brought up an interesting point, and this is kind of the opposite of his. This is a patient who was at the VA and underwent a PE study, and there's this big, region of lower attenuation contrast in this vessel here, and when you look on the lung windows, then you see all of a sudden this vessel goes away. So it's kind of the opposite of the whatever double. What was the name of the sign, Howard, with the parallel bronchi? Yeah, this is like the double bronchus now instead of the the opposite, because you now have air in this pulmonary artery from just an injected air embolism next to the bronchus, right next to it. So just again underscoring the fact that you shouldn't have either two airways or two vessels side by side, and I think you can see it going up into these branches as well, where you have it paralleling the airways. And I think that as a result, you had that little air causing slow flow and caused the contrast in this portion to be a little bit lower attenuation. And then of course they repeated this the next day, and now you can see there's no question that there's nothing actually in that airway or in that artery. There was all just air. So just the idea, underscoring, it's right here actually, this one, because you can see that airway next to it again, and then just reinforcing this idea that you should not see two of the same structure paralleling each other in the lung.
Yeah, I do remember the case you showed us before. That was great, yeah.
All right, so here's the exciting one from yesterday, or from 2 days ago, I guess. This is a newborn. This is day 0 of life, and this is a known diagnosis from prenatal imaging, and you see this big bulge over the abdomen. This is the umbilical cord here, and notice what you don't really see here in the chest where it should be, which is the heart. And you can see on the CT that we did right here that the heart is not where it should be. And of course, this is ectopia cordis. And I'll go through the anatomy here in a second because we're still trying to figure out things ourselves. But this is part of a true pentalogy of Cantrell. So this is the thoraco-abdominal syndrome, and it's all due to a big midline defect. And so you have an omphalocele, you have this large anterior wall defect, and there's variable amounts of diaphragmatic defects, pericardial defects, cleft sternum, with or without ectopia cordis. And then the fifth thing in the pentalogy is the presence of congenital heart disease. Now, it's usually tetralogy or VSD or something. This is kind of an interesting case because this is the aorta here. We know it's the aorta. You can see that the coronaries are coming off. And what's interesting, and I'll be curious what everybody's opinion is on this, that the coronaries look like they're coming off of the cusps that they should be, like the right cusp and the left cusp. And the non-coronary cusp is more located posteriorly, as you would expect in a patient with a normal arterial relationship as opposed to transposition. You might think that this is a pulmonary artery next to it, but this is actually the left atrium. These are pulmonary veins that are going into this, which is going into the ventricle here. So this is a large overriding aorta, and we're calling this, we being everybody, including the peds congenital folks on echo, that it's just a pulmonary atresia with a large overriding aorta and a big VSD here. But what's interesting about this, and I don't know really where you draw the line between pulmonary atresia with big MAPGAs and whether or not this could just be a variation of truncus arteriosus, because you see that there's an aberrant right subclavian artery, but there are these big vessels coming off of the aortic arch, the undersurface, and you can see one here for the left, one for the right, and those are really the pulmonary arteries. You can see they follow along the bronchi and supply the arterial blood. And then there's another one here that's more of the typical bronchial, like a MAPGA, that also is supplying portions of the lung. So I don't know if anybody has an opinion on what you would actually call this. I don't think it really matters in this point, in this instance, other than the question is whether or not one of these is a ductus and they need to be phosphodiesterase inhibitor or prostaglandin inhibitor dependent so that this doesn't close. But I don't know. It's a very interesting case.
Travis, I wouldn't call it a truncus because the branches to the pulmonary arteries aren't coming off a conal structure.
Yeah.
They're coming off the arch, so that would be presumably the fourth primitive aortic arch.
Yeah.
Different structure from the conus. So I think because the truncus forms because of the failure of the spiral septum to form normally.
Yeah. I mean, they have the classification, the different types of truncus, where some of them come off the aorta, but again, I don't. It's really more of an academic point, but it's very interesting.
They're just really big MAPGAs that form.
Yeah. But a pretty dramatic case. The first one of these, I know there was one in our teaching file that I had shown a couple of years ago, but this is the first time I've encountered an ectopia cordis like this. So,
were there any other anomalies outside the chest?
The omphalocele, I don't know, and I actually looked. The airway branching pattern was normal.
Yeah.
This is just shortly after birth, so I don't know if some of this is aspiration or if it's just, I don't know. We don't see many day zero CTs of lungs. So.
Yeah.
All right, let's see. Here's an interesting case. This is a case that kept on giving us more interesting things. So here's the original radiograph, and I'll let you look at the PA and the lateral view. If I can unsync them. And you can see that there's this superior, well, what some people might call superior mediastinal mass, or you could just say middle mediastinal mass, but we know it extends, looks like it extends outside the cervicothoracic sign because you have deviation of the trachea to the right, even up in the neck. And it looks more middle mediastinal here. It's displacing the trachea anteriorly. This is an older woman who I'm unsure of how symptomatic she actually was from this. But as you might guess, with the deviation of the trachea all the way from the neck, and this just looked like a big goiter. And this is also a reminder, that oftentimes goiters go into the middle mediastinum as they descend along the trachea, rather than into the anterior mediastinum, as we were all taught in medical school. But this was a goiter, and they took it out, confirmed that it was a goiter, and then 2 days ago, she was a couple days post-op, she developed sudden onset of dyspnea, and actually, I'll put these up side by side so you'll just see the difference here. But she develops pulmonary emboli and has pretty profound CT indicators of right heart strain with pretty substantial RV dilation. You can see how big the RV is now. The LV is very squished. The RA is big, and it's a moderate burden of clot. And they were unsure if she was actually going to make it through the night. She did not undergo TPA or anything, but what they did do was that they did ECMO on her. And I'll show you that what's interesting here, a couple things. So this was the next day after ECMO, and a lot of the PE is already lysed. There's some that's still left. Her right heart findings improved a little, but what's interesting now, as you see in her aorta, I showed that case of aortic smoke last week, And this is a case, again, along the anterior portion. And I don't even think this is from flow as much as it is maybe just from slow output and almost gravity with a fluid contrast level in her aorta. And some of this may be due, to her reduced cardiac output. But I thought this was kind of interesting. And it just so happened because she was on ECMO and they weren't sure if they were going to get an adequate PE study with the ECMO, that they went ahead and did a 90-second phase. And you can clearly see that the smoke is gone. So it was just a contrast fluid level in the aorta. So another nice artifact. And I think this one may be just more gravity dependent filling due to her reduced cardiac output. So
cool.
Yeah, just a nice collection of multiple things.
Travis, I thought early on you made a good point, that as you said, they always teach thyroid in the anterior mediastinum, but I would argue almost all the time it's more retrotracheal.
Yeah. Yeah, no, that was taught to me early on in residency too. There's no 4Ts in the anterior mediastinum really. When the thyroid is much more common to descend along the trachea like this. And this is always a big clue when you see that mass effect on the trachea when it extends out. And as Howard always likes to talk about, the cervicothoracic sign like this.
Yeah.
All right, here's a fun one from our ILD conference. And this is a lady, she's middle-aged, and what's interesting is she'd had a gastric bypass, and you can see here, and that may or may not come into play here, but she developed, and I don't know exactly when that was, but she said several years, and this was all done at an outside hospital, and then she got referred to us. Her lungs don't look that terrible in 2014, and of course these are really thick slices. There may be a little bit of mosaic attenuation, but then I'll just show you a series of different studies. On this study, she's got a lot of patchy ground glass, and it's fairly diffuse, meaning all lobes are affected. It's certainly not a uniform process by any stretch of the imagination. Not much to go on with this one. And then I'll just, again, why sometimes having a lot of different studies is very important. Here you still see ground glass opacities, right upper lobe, but more on the left. And you can kind of tease out some of these areas, maybe more discrete little nodules and nodular ground glass opacities in the left lower lobe. And so we're going through this in our ILD conference and just looking through, here's 2017, looks more like that original one did. A little bit of ground glass, maybe some of these are more discrete. And then I think it was one of these studies that it was this one, where you see now she's symptomatic again, and it's much more asymmetric on the left side, but still more of a centrolobular process and faint centrolobular nodules. Some of the areas more discrete, little lobular areas of consolidation. And, as they're talking, no history of exposures or anything. And so, I thought that the most likely thing in this, just given it was recurrent and it was slightly asymmetric, was aspiration, especially given that she had this surgery and her esophagus was a little dilated. I didn't really go back to that, but she had an open lung biopsy. As you can see, she had a surgical lung biopsy on the left, and she did have some foreign vegetable material and whatnot in her airways. So it was a confirmed case on path of aspiration bronchiolitis. But I just thought, and I don't know, other than the fact that they're central lobular nodules, and it makes you think of a cellular bronchiolitis, that it's recurrent and that it's asymmetric, at least on one of the studies. And that's what led us down that direction. I don't know, it's a pretty dramatic example, and oftentimes we see more discrete tree and bud nodules, but I'm curious what you guys think. We have path proof of it, but if you've seen cases similar to this.
And on all the studies you showed, it had a subtle but real posterior sort of dependent distribution. And also in every single study, the esophagus was abnormal and had debris.
Yeah. And that's one of the things that I brought up too, was the fact that she'd had a gastric bypass. And I wonder if this, kind of contributed to it. But it's an interesting case. I think it's just a reminder not to forget about aspiration.
Right there, Travis, you can see actual food in the esophagus.
Yeah. So. Yeah.
Wow.
All right.
Yeah. Very kinetic.
I'll show one more just really quick. This one's not that exciting, but then that'll give Jeff the last quarter of an hour. I think this one's more of just a reminder. Now, this guy, he had trauma to his shoulder, which is irrelevant to this. this is 2015, and he had this subtle little thing right here, which is not just a vessel. There's you can see an intercostal vein on the left, or on the right. And then in 2017, this is a study that I saw a follow-up, and all of a sudden this thing has blown up. And you can see it's slightly hypervascular. And if you had to put it anywhere, you'd probably put it in posterior mediastinum. And of course, when you look down at the abdomen, you can see that he's had a right nephrectomy. And so he had a renal cell carcinoma on the right, no known metastatic disease. And so they, I was, again, always think about metastatic disease and never bet against cancer. They went to try to further characterize it with MR, to see if it was a nerve sheath tumor, which this didn't really help that much. It was it certainly wasn't a cystic schwannoma or anything. It was not that bright on the T2 images that you see here, and it enhanced. So I don't think this really added anything to the differential, because it needed to be biopsied or taken out anyway. But it did turn out to be just a slow-growing renal cell carcinoma metastasis rather than a nerve sheath tumor. So I'd call this posterior mediastinum. It's loosely posterior mediastinum, but just, I guess the moral of the story is never bet against cancer, even if it's slow-growing.
And just a solitary metastasis, as far as one knows, huh? That's unusual.
Yeah, and it was, maybe probably through the lymphatics, maybe via the thoracic duct, it ended up here. It's not a Virchow's node, but just trying to think of why it would end up right there. I don't know. That's the best I can come up with. But you can add that to your differential if you need one for your mediastinal talks. So.
Thanks, Travis.
All right.
Okay. You see our chest röntgengram, as God would say. All right, so this is a companion case to yours, Howard. So this is I forget how old, middle-aged man who presented with cough and was noted to have this abnormality on a chest radiograph, and this was about 4 years ago. And here is the CT from that time. And you can see there, and these unfortunately are thicker cuts, but done elsewhere, but you can see there's a nodule mass. There's surrounding ground glass, but it appears to, it's in the middle lobe there and crossing some kind of fissure there, spiculated, but looks pretty ugly. If we go to the soft tissue, which I hopefully did include, yes, we see that it's not particularly that low attenuation. It's ISO to the blood pool, so probably in the 40 Hounsfield unit area. And so he had some type of biopsy done elsewhere, and it was read as a lipoid pneumonia. He did have a history, it was documented, of exposure to Vicks vapor rub, so another one, but in further questioning when he was sent here for opinion, that history was a little bit weaker. It didn't sound like it was a routine user, unlike the case I showed last time. So then we have a CT scan from this year that shows what now has developed, and we see this cystic, bubbly fluid collection mass. There's some well-confined ground glass around it, so part solid component filling most of the middle lobe. And then it's important to recognize these little guys scattered throughout, these little Cheerios. Now, you might say these are, they're inflammatory nodules, that endobronchial spread of debris, which is fair. But there's another CT, a later CT. This is from the PET, but those nodules were there on the PET too. And you can see some of them have little cysts in, the little Cheerios. Some are more solid, and they're in both lungs. You can see that kind of looks like your case there, just at a poor spatial resolution. So this is, and then I'll fuse the PET here and just show you how much activity is in this. It's probably not windowed exactly right, but this is another mucinous adenocarcinoma. And so this is that endobronchial spread or aerogenous spread of tumor that, it's funny, I think we all recognized, for probably dating back to when we were, in early practice or training, we saw these adenocarcinomas that involved both lungs, yet there was no mediastinal disease. And we always called them METs, but I remember when I was a fellow, we talked about spread through the airways. And it wasn't until a few years ago that someone finally wrote this up in the Yellow Journal. But it's one of those moments where you said, why didn't I think of that thing? But anyway, it's a well-known pathway, because these tumors, there's a lot of mucin, so there's a lot of secretions, they float in it, and it just takes one or two to get to the other side that are able to adhere to the airway epithelium, somehow get into the lung and start growing. At least that's the presumed mechanism. So that's a mucinous tumor. And they're tough to manage because they usually are KRAS positive, so they don't respond to the immunologics, and you can't resect them. This is just a quick case of a patient who was seen, and we didn't have a lot of history on him at the time. And you do see a CT, correct?
Yes.
Good. He had these very extensive ground glass central lobular nodules in the upper lobes, and then he had this more solid nodule. And as I scroll through, you'll recognize that there's sort of a gradient, and as we get to the bottom, they're almost non-existent. There's a cyst here and there. So this was interpreted originally as, HP, hypersensitivity pneumonitis, versus respiratory bronchiolitis in a smoker. The only problem with that is if this were HP, you would expect him to have a lot of symptoms, which he didn't. And if it was RB, I've not seen RB give nodules that were this big. They're almost acinar in distribution, that they're filling most of the lobule. They're usually very smudgy. Even patients who have a clinical diagnosis of RB-ILD don't usually have nodules this big. And you could almost excise these. And it wasn't until we saw another scan on him and Doug asked the right questions, and the clinician who saw them had to actually go back and ask him. Turns out he was on disability, so he's working at a desk job, but when you find out what he was doing before that, it turns out he had been welding for many, many years. So this is a presumed case of welder siderosis, which would explain the low number, the minimal symptoms he had. And it's probably related to his smoking. He was a smoker, but I think most people would agree this looks more like a typical siderosis case than RB. I mean, there could be some RB mixed in there, but I've just not seen these nodules this discrete and this large with RB.
No, that's a great idea, because iron is one of those potential non-fibrotic pneumoconioses.
Right.
So you see a lot of it without the scarring and so on associated with it. So non-fibrotic siderosis.
Yeah. And if you look at this radiograph, you can see there's that that upper lobe nodule, and this was a year before, so that's probably a lymph node or some non-calcified granuloma. But the lungs themselves, I mean, I'm on my a little screen right now, but they don't look. It's hard. You don't really see them, which is typical of this art with RB because they're so poorly defined. Okay, this is an interesting little pitfall case I came across. This is a patient with a Merkel cell tumor of the head and neck. And I got all excited because I was complaining they hadn't given me enough history. But if you look at the radiograph, you can see all these cutaneous nodules all throughout. And I was looking at the CT, and I was taken back by all these nodules. And obviously, Merkel cell frequently involves skin, but it can metastasize wherever we want. And he actually does have a bone metastasis involving his, if I remember, it was the scapula. Yeah, he's got a lytic lesion right there. But that aside, the reason I'm showing this case is he's got all these cutaneous nodules. So obviously they could be Mets, but I was wondering if, could these be neurofibromas? But in thinking about it a little bit more and getting a little bit more information, I remembered that the neurofibromas are deeper in the skin, but it's hard to tell because some of these do protrude down there. And so I thought this guy might have had NF1 or something, and they just didn't bother to mention it. But it wasn't until I was digging a little bit more from a different clinic and was able to find this picture. And these are all actinic keratoses, mimicking metastases and neurofibromas. And so they've actually biopsied a couple of these, and they're all, I mean, he's just got tons of, I didn't even pull all the pictures. I was able to do this one because I could cover the face. But these are all actinic keratoses. So he had a long history. I don't know exactly what his occupational history was, but lots of sun exposure over his life. So
wow,
a pitfall there for nodules. Let's see. This is a case, and I'm curious, we were talking about it this morning. I'm curious what you do with this. So this is a patient who has what looks like rounded atelectasis. We see pleural effusion, we see pleural thickening, and if I switch to the lung windows, you can see we have features of rounded atelectasis. We see volume loss spiraling in, so sort of a hurricane sign, and in patient, no previous surgery. I'll come back to the CT because there are a couple important features, but this patient actually has a cancer in here, and I'll show the PET just to make it easier to see. But you can see in the right lower lobe, there's actually this hypermetabolic mass tucked into that rounded atelectasis. I'll come back now to the CT scan here. And there's a couple clues, but again, it's challenging. First of all, we see the spiraling of the airways, but there's always this solid component here that seems to be deflecting them and even sort of narrowing them. And then you see the nodularity along the pleural surface too, along the mediastinal pleura, which is not typically a good sign. We don't like to see that in the setting of benign pleural disease, and this sort of lumpy, bumpy stuff too. But I don't know, when you guys see a rounded atelectasis, I mean, there's always been reports and people have mentioned they've seen one here and there, but how often do you just say it's rounded atelectasis and be done with it versus do additional workup?
I do. I just say rounded atelectasis. So, this is really unusual, and I don't know what to make of it, because otherwise, just looking at the CT that you showed, it sure looks like just rounded atelectasis.
It really does.
I think now is this histologically proven tumor for sure? Because if I remember, rounded atelectasis can be and has been reported to be PET, or I should say FDG Abbott sometimes. So
Yeah,
there's no.
I believe it was. Don't quote me on that. One of my colleagues shared this case, but I'm almost positive it's histologically proven. And the other thing is the metabolic activity is distinct from the rest of the peripheral portion of the mass. It's only that solid component, which would be a little unusual. So this part right in here, it's not involving the lateral portion, which is the rounded atelectasis. And I guess you could get a rounded atelectasis from a tumor because you could get a pleural reaction to it, pleural thickening or fixing of the pleura that could lead to it. But in talking, we were talking about this morning, and one of my colleagues commented that, Chris Meyer commented that everyone he seems to know has seen at least one case of this. So it's always kind of, how do you manage it? This case has some other clues, but they're subtle. And when you have a lot of pleural stuff going on, it can be tough to determine what's going on. So yeah, I've always reported as rounded atelectasis as well. Usually they have a history of cardiac surgery or empyema or asbestos exposure. But yeah, it's kind of one of those ones, it makes you think about it, before you just call something atelectasis.
Yeah. If that's tumor, sometimes you just can't win, as it were, not to be too glib.
No, I know what you mean.
Yeah.
So I usually do follow those up, and unless you have a prior exam, because of the desmoplastic response from adenocarcinoma could be very similar. I mean, I probably would have just called that round atelectasis too, but it can be very confusing with the desmoplastic response, and then you can get loculated fusion from cancer too. So
yeah. All right, I'll show this last case. It's a nice case where the lateral is a good case. So this patient has a history of, and I'll start with the old CT, of an acute type A aortic dissection. Nothing special about it. Looks like a typical one. So patient was repaired and had ascending graft placed. And then this is a radiograph. Now, I'm showing them out of order, but for teaching purposes, you can see, if you look on the frontal radiograph, looks like a typical, got some wires, there's the aorta, it's a little tortuous, but you wouldn't make much of it. But what's nice is you have on the lateral here, you've got the ascending aorta. Now I'll pull up the SAG. So this is a newer CT, and you can see that there's this pseudoaneurysm that corresponds to this extra little bump here on the lateral. And I wish I had unfortunately we didn't have a pre-pseudoaneurysm PA and lateral in our system, but that you can see there it is right there. There's a little kink in the system, but there's a little defect here. So it's at the proximal at the distal anastomosis there, so a common location for it. And then here is the corresponding axial images, and you can still see there's the residual type B. You've got flow in both lumens, you've got some thickening in the wall there, but you have this outpouching right anteriorly there. So just a nice lateral radiograph showing filling into that retrosternal space with an extra bump. It would be a better case if I had another older lateral that didn't show it. But if you see the aortic contour, there shouldn't really be an incisura right here, a little divot in there. So just kind of a fun case. And it's 3 o'clock, so I think we'll call it a week. And are you guys around next week?
I'm around. I'm
Okay.
working. So.
Yeah, me too. So, well, let's plan on Thursday again, okay?
Okay.
Okay.
All right,
Yeah.
take care, everybody.
Have a good Christmas, everybody. See you.
Yeah, you too. Happy
Everyone.
New Year as well if we don't talk to you. Bye-bye.